Thank you all for coming to today's Maternity Action Plan work session. We are absolutely ecstatic to get into today's topic. But first, before we can dive in, we should discuss what the Maternity Action Plan is. Um, and so, in partnership with many partners and advocates, such as yourself, some of you guys as maternal health stakeholders, the Maternal Action Plan was created to create a overall holistic approach and directional path forward to address New Jersey's maternal morbidity crisis. So we understand that women, specifically women of color, experience birthing disparities at much higher rates than other birthing persons. And so, what the Maternity Action Plan hinges on is four priorities to improve maternal and infant health throughout the state. And what those are building the maternal health workforce, data, collecting and using data properly to improve equity and quality, reforming payment systems, and improving community-based social supports. So next slide, please. So the evolution of MAP has been quite fascinating. So we, when we first began, we were doing this work, and it started during the height of the pandemic. And we were able to do, through our research, find that by breaking down systemic racism, by creating authentic hope and improvement, improving workforce, that we could ultimately evolve the maternal landscape within the state of New Jersey. So next slide, please. And that was through using your feedback as well. So we've had some previous maternal action plan work sessions in the past. Some of you might remember some that were actually related to data. Some were collecting and using REAL, which is race, ethnicity, and language data to improve health, equity, and quality. And then and in that particular MAP event, we were identifying disparities for equitable causes, really for the first time, like identifying during that time frame the way that we could standardize race, ethnicity, and language as a tool in data to identify further disparities. Another MAP event that we hosted was MAP to Action, where we collected and used data to improve equity and quality. So we talked about elevating the lived experience of individuals with clinical outcomes, and we talked about supporting person-centered care. So for today's event, Data and Practice, Turning Maternal Health Insights into Action, we are really excited to kind of explore various different data topics with you. We're going to be highlighting some live demo sessions like from the Maternal Health Data Center. And we will even get to talk later on about AI and technology and what does that look like in data and how does that impact us, right? So why does data matter? Why does data matter? Data helps identify disparities, measure progress, inform policy, strengthen accountability, and ensure maternal health solutions are guided by both evidence and lived experiences. So we're making sure that data today is no longer biased, is no longer narrow-minded, but is casting a wide net and is capturing a wider picture of the realities of what is really happening in the world today. Next slide, please. So, insight into action. What does that mean? So, across today's session, we'll focus on key areas where we're going to talk about where data can essentially be practiced in a way to move maternal health equity forward. And two of those ways that we'd like to highlight is one, learning to navigate maternal health data systems. So you heard me tease a little in the beginning that we're going to be looking at some data centers, some web applications, some demos, right? And so what does that look like? What does the state of New Jersey already have in place? And like, what can we use with that information? And then considering how we use, compare, and identify data. How are we using the data? How are we exploring open data? How are we pairing small data? What does small data mean? And how do we pair that with lived experiences of individuals and their birthing experiences, right? So today's presentation and breakout discussions will map these two areas specifically, and we want you to think about those topics as we move through the presentation. Next slide, please. So, I have the great pleasure of introducing some wonderful people. So we have our great speakers here, but I will briefly go through each person's bio a little later when we go through the presentation, but these are their amazing faces. Next slide, please. And then just really quickly, I wanted to go over the agenda with everyone. So, as you know, we have our opening remarks. Our first presentation will be with the New Jersey Department of Health. We will specifically be highlighting the New Jersey Maternal Data Center presentation, and there will be a Q&A followed by that. Our second presentation will be on small data community engagement and AI presentations with Dr. Sorry, we'll share their names a little later. And then we'll have breakout discussions where we will discuss everything in further detail with your groups, where you'll get to detail some of the events, ask questions, talk about the work that you're even doing. We'll do a report out and a fuller group discussion following the breakout rooms, and then we'll do closing remarks and next steps. So thank you. And just give me one second.
Thanks, Max. I will take it and move to our first presentation. So, thank you all so much for attending today. We have a packed agenda. As always, you can see we're always very ambitious, but I'd like to officially invite our presenters from the Department of Health to our virtual stage. And if you'd like to share your screen, you're welcome to. You got to see their faces earlier via our slides, but I'd like to officially welcome our Department of Health team. We have Mehnaz Mustafa here, Dr. Stephen Firsing, and Dr. Jordan Steiner, who we will be officially referring to as Stephen and Jordan from here on out. But we are so pleased to have you with us today to present about the Maternal Data Center and all of the data work that the Department of Health is doing, and then to demo that. I will also say, because we are squeezing in a lot and we have some time dedicated to Q&A, our Department of Health folks will also be joining us in our breakout room so we can continue more discussion there too. So I'll turn the stage over to you. Welcome.
Thank you, Kate, and thank you for the introduction as well, Mixile. Good afternoon, everyone. My name is Mehnaz Mustafa. I serve as the Chief Data Officer for the New Jersey Department of Health and the Assistant Commissioner for the Division of Health Data and Analytics. A little bit about Health Data Analytics. Our division includes the Office of Vital Statistics, the Center for Health Statistics, Healthcare Quality Assessment, Performance Management, and the Centralized Data Hub, which includes the Maternal Data Center, which is what we'll be focusing on today. Next slide, please. Just a quick outline. We're just going to start by reminding all of us on what the state of maternal health was in New Jersey before the Maternal Data Center was created, and really what led to the creation of the Maternal Data Center. Do a very brief overview of the legislation that created the Maternal Data Center, what data sources we use and how we link them. And then my colleague Jordan will do demos of our two public-facing data tools and how they can be utilized as valuable resources. Finally, we'll end with some future growth plans for the Maternal Data Center and hopefully leave adequate time for some Q&A. Next slide, please. So I'd like to take us back to 2018. According to the National Center for Health Statistics at that time, the maternal mortality ranking ranked New Jersey as 47th in the country among all states for maternal mortality. What was even worse was the racial ethnic disparity in pregnancy-related maternal mortality rates, with the mortality rate for Black non-Hispanic birthing people being 7 times higher than white non-Hispanic birthing people. And what was becoming more widely known are the social and structural factors, also known as social drivers of health, provide a key framework for interventions for improving maternal health outcomes. Next slide, please. In 2019, Nurture New Jersey was launched so that there could be a statewide focus on eliminating disparities mentioned in the previous slide, and the Maternal Data Center was a part of the strategic plan. At the same time, 2 pieces of legislation were passed, which addressed making data and information available publicly and required the New Jersey Department of Health to track maternal health outcomes in hospitals during labor and delivery. And we were also asked to be transparent about what the data was showing. Next slide, please. The next 2 slides will talk a little bit about the legislation. The first one being the creation of the Maternal Health Hospital Report Card. The legislation required this report card to be published annually on the Department of Health's public-facing website and make data available at a hospital level for maternity care. The legislation stated that for each hospital, we had to publish the number of vaginal deliveries, the number of cesarean deliveries, rate of complication for both vaginal and cesarean deliveries, which needed to include maternal hemorrhage rates, laceration, infection, or any other complication. And it did leave room for the Commissioner of Health to revise or add complications or any other factors as deemed necessary. Next slide, please. The Maternal Data Center legislation came in 2019. It required the Department of Health to collect and analyze data on maternal health and make data available on a public-facing dashboard. The data was also required to be shared with the Maternal Care Quality Collaborative, the Maternal Mortality Review Committee, all participating healthcare facilities, and any other stakeholders as needed. The Maternal Data Center is also required to develop a hospital-facing portal whereby data can be shared in near real-time manner with participating hospitals. Next slide, please. So what does the Maternal Data Center look like and where are we today? On the public-facing side, we have the Maternal Health Hospital Report Card. It was last released in January 2026 using data from 2024, and the Maternal Data Center team is currently working on the next release scheduled for early 2027. We also have the Hunger, Food Security, and Maternal Health web experience, which was released in 2025, with newer web experiences being planned currently. And on the hospital-facing side, the Maternal Data Center has also built a registration-based hospital-facing portal, which completed multiple rounds of beta testing with select hospitals and was launched statewide earlier this year in April 2026. Next slide, please. So this is a question we get asked a lot. What data do we use for the Maternal Data Center? First, there's the New Jersey birth certificate data from NJ-VERY, or the Vital Events Registration and Information System. This data is entered electronically for all births in the state. And in the case of births in acute care hospitals, this data is entered directly by birth clerks at each of these facilities. While the birth certificate contains a lot of information on clinical data, such as maternal risk factors and complications of labor and delivery, as well as sociodemographic data, such as race, ethnicity, age, and education, it does not, however, contain what is needed to calculate severe maternal morbidity. For that, we look to our second data source, which is the New Jersey Hospital Discharge Data Collection System, commonly referred to as the Uniform Billing or UB data. This data source contains diagnosis and procedure codes for all hospitalizations in New Jersey, including delivery, and these include ones that are used to identify severe maternal morbidity indicators. These two data sets are matched, and a linked analytic data set is then generated. Lastly, for those types of data that have been identified based on research and feedback from users as important or needed, but do not get collected by data sources in the Department of Health, we rely on an annual survey that gets administered to all birthing hospitals. Next slide, please. So today, the first public-facing data product that I'd like to introduce is the Hunger, Food Security, and Maternal Health web experience, which has been developed by the Maternal Data Center in collaboration with multiple stakeholders and divisions within both internal and external to the department. Next slide, please. Just to give a little bit of background and context on why this product was developed. I'm sure this is not any brand new news to anyone on this webinar. There has been a steady increase in food insecurity in New Jersey. Nearly 12% of the state population was determined to be food insecure in 2023. Food insecurity, as many of you know, affects maternal health conditions such as obesity, hypertension, or gestational diabetes. On the infant child health side, food insecurity impacts health complications such as birth defects and asthma, as well as developmental challenges. The New Jersey Economic Development Authority in 2022 designated several parts of the state as food desert communities. In these communities, maternal comorbidities such as hypertension, diabetes, preeclampsia, chronic cardiac diseases were 12% higher than communities that are not food desert communities. Next slide, please. Developed in 2024 and released in January 2025, the Maternal Data Center worked to put together a web application that focused on the relationships between food insecurity and maternal and infant health. This web application explores the links between food insecurity and other social drivers of health. The application also provides resources for programmatic interventions that are focused on reducing food insecurity, such as WIC, SNAP, and the Healthy Corner Store initiative in New Jersey. Next slide, please. Before we delve into the actual application, a little bit about the data and the technology behind this application. The data sources include the Healthy Corner Store initiative and WIC program data, SNAP data, census data, electronic birth records, and hospital discharge data. Some key features are listed on this slide. Tableau dashboards highlighting birthing person demographic data in the food desert communities. There are ArcGIS maps showing locations of the food desert communities, as well as locations of WIC SNAP accepted stores and the Healthy Corner Store initiative locations. Also note that the WIC SNAP and Healthy Corner Store locations are updated twice annually, and the maternal and infant health data are updated yearly around the same time as the maternal health hospital report card. The American Community Survey and related data is updated as applicable when available with current year updates. And now I would like to hand it over to my colleague, Dr. Jordan Steiner, to walk us through a quick demo of the web application. Jordan, over to you.
Wonderful. Thank you so much, Mehnaz. I'm now going to reshare my screen to bring us to the demo. Okay. So here you have to get to the Hunger, Food Security, Maternal Health web application. My colleagues should be sharing in the chat how to access this from our Maternal Data Center. You have the Hunger, Food Security, Maternal Health story map, as well as dashboard. I will get to the dashboard at the end, which focuses a little bit more on demographics, health outcomes, and comorbidities. But I will first bring up the story map, which is the focus of our presentation. Within the web application, you will see multiple tabs, a summary tab, a how to use tab, story map, and data maps, etc. The first tab really provides a kind of high-level overview of everything that is covered in the story map and the data maps in plain language, how to use to how to really navigate everything you're looking at, and then we will delve into the story map and the data maps. So to start us off, our story map begins really providing an overview of what food insecurity is, as well as some conceptual frameworks to guide the work, some of which is cited from the New Jersey Office of the Food Security Advocate. We delve into some overall statistical information about food insecurity in the United States, and then specifically in New Jersey. As Mehnaz said, nearly 12% of the state's population in 2023 were deemed as food insecure, which was a huge impetus for us focusing on this issue. And then some overarching information of how food insecurity really relates to poor maternal, infant, and child health. We get to the objective of the story map and then into our first map. So our first map focuses on the food deserts, as Mehnaz already discussed, that were deemed and determined by the NJADA, that basically define geographic areas where residents have limited access to nutritious food. And you can see how some of these were defined. You can search anywhere on this map or delve a little bit closer into the food desert communities, specifically on the New Jersey map. We then get to our first map, which we are showing maternal comorbidities on the right of our slider and poor infant outcomes on the left. You will see the gradient of the greater percentage or severity of maternal health issues or infant health issues are darker colors, and lighter colors show lower percentage. And so you can see here where maternal health issues within our food desert communities had significantly higher maternal health conditions. So again, high blood pressure, diabetes, obesity, preeclampsia, chronic cardiac disease, or poor infant health outcomes. So premature birth, low birth weight, NICU admission, or infant deaths that occurred before hospital discharge in comparison to municipalities that had greater food access. And so this shows you an ability to kind of swipe back and forth and see a gradient of the severity of these maternal and infant health issues layered on top of the food desert communities. We then get to some maps that are focusing on the most severe food desert communities in New Jersey. So we are focusing on Camden and Atlantic City, which were deemed as the most severe food desert communities. And so here you see a comparison in disparities between Camden and a nearby municipality, showing maternal health issues between both. So areas with more severe food desert community issues, as well as comparison to greater food access. And you see that same with Atlantic City with a comparison to a nearby municipality, and the same with infant health. So you see the percentage kind of difference to show some of these disparities. We then come into some maps looking at social drivers of health within and layered upon the food desert communities. Some of these factors actually make up some of the food desert factor scores within the food deserts. So the first one being low vehicle ownership. So again, our swipe maps show low vehicle access on the right, percentage that is darker is kind of a greater issue of no vehicle ownership, and lighter, less of that particular social challenge. All layered against or on top of the food desert communities. And again, you can delve in anywhere on the map on any of these maps to get more information on particular percentages and particular census tracts, etc. We have a second map looking at low access scores, so the extent to which residents are underserved by supermarkets, with that same gradient looking at kind of lower severity or higher severity, all layered on top of the food desert communities, and are able to delve into any areas of the state that you're interested in, as well as poverty by race, ethnicity. So then we get into our programmatic intervention that we're highlighting. So we are focusing on the Healthy Corner Store Initiative, WIC, and SNAP stores. So the first and kind of the focus is the Healthy Corner Store Initiative. That is a program from the Department of Health that aims to improve access to nutritious food and beverage options in corner stores in food insecure communities across New Jersey. And some information here and how many stores are kind of available in New Jersey and some general information. Then we get to our first map looking at these programmatic interventions, all again with the hope of mitigating some of the maternal and infant health issues we've highlighted. So this first map looking at WIC and SNAP certified stores on the left of the swipe map, and then Healthy Corner stores on the right, and the ability to delve in any area of interest to actually see where these stores are located. And these are all mapped on top of the food desert communities. And then two programmatic spotlights, one focused on the Camden area. As we highlighted, these were the most food insecure communities, Camden, Atlantic City. So particular stores, Healthy Corner stores within SNAP stores in the Camden area, as well as the Atlantic City area, to show some of these programmatic interventions in these particular areas. And then highlighting some resources such as Connecting NJ and food security, food access information. I'll go very briefly to the data maps as we believe this is of particular interest to this audience. So the data maps you'll see here, there's a number of different data maps that a user is able to delve into for more detailed information. I will just highlight a few. One being maternal comorbidities and food deserts, which allows you to pick a number of different maternal health outcomes. Again, the gradient of higher and lower percentage based on the colors, the darker colors and lighter colors, an ability to really look at particular percentage of birthing individuals in certain areas. And you can see layering of the food deserts on top of these maps as well. Another one of particular interest might be the nutrition program eligibility. So looking at with eligible families, SNAP recipient households, again, looking at some layering here of the food desert communities, an ability to look at where particular WIC Healthy Corner stores, SNAP stores are, and all mapped on a particular map focused on percent of households with children receiving SNAP. And another one of interest might be the social and environmental accessibility. So again, these were highlighted in the story map, but these are in more depth. So no vehicle ownership, for example, low access score, and again, the gradient from higher percentage to lower percentage. And any of these maps, you can search a particular place as well, or just choose a point within the map, and then you can see a lot of different accessibility metrics here as well. I will go very briefly to our data dashboard, which can be accessed, in multiple ways through our main MDC site or through the story map itself. This just allows another way to look at the data. So one being an ability to look at a particular food desert community and look at a race ethnicity breakdown, look at by year, as well as look at particular comorbidities or outcomes, anemia, hypertension, a whole number you are able to select here. So that's just a few features. And then we ask everybody who uses this, of course, to fill out a feedback survey if possible, as we always like to iterate and improve upon what we are doing. So that was the demo. And I will now go back to the PowerPoint. We also have a QR code here if you are wanting to, I think it's in the chat as well, but go directly to the web application yourself. And then just to talk very, very briefly about some of the results and impact of this web application. So this was released, again, initially in January of 2025, has been continually updated. And we've, gotten an increase in views, which tells us that hopefully it's being used, kind of almost 8,000 views. We're very intentional about wanting this web application to be used in the community by a whole host of maternal health stakeholders and beyond. So some kind of highlights is state officials have highlighted this web experience in legislative materials, budget sessions. There's been continuous discussions that we've had with local community foundations, the Office of the Food Security Advocate, community health workers, et cetera. It's gotten some press from online mediums, and we have gotten good feedback that there's strong usability of the web experience and that it is used to inform decision-making among healthcare, food assistance providers, etc. I will note, as I did at the beginning, that all of our web applications are fully mobile friendly and have been reviewed for accessibility features as well. So that's very important for us as it's in the public realm. I will now hand it over briefly to Mehnaz before our demo.
Jordan, there's a question before I just move quickly. Can you go back to the QR code so that one of the participants can just... All right. While this is happening, let me just give a little bit of intro into the Maternal Health Hospital Report Card. I think many of you have seen multiple iterations of it, and B, it has been widely presented. It currently has data from 2018 to 2024, and is an interactive website providing information on all general acute care hospitals that perform labor and delivery in New Jersey. Please note that the 2016 data is archived in the Maternal Data Center website, but is kept separate because we were using a different format and a different technology platform for that data. I will now stop talking and hand it back to Jordan to do a demo, a very quick demo of the report card. Thank you.
Thank you. So now I will share my screen again. Okay, so hopefully everybody can see my screen again. One of my colleagues will share in the chat the link to the report card. So again, a very, very quick demo of the report card. You get to it from our Maternal Data Center site. You see multiple dashboards, which I'll delve into a few here, as well as our documentation. So one being summary of findings, which summarizes all of our analysis from the particular year of focus. So this year, 2024. Methodology, which describes our data sources and our data analysis. Our measure algorithms, which describes our variables. And then I will just delve quickly into our hospital-specific dashboard and then one statewide dashboard. So this is probably the kind of the most used dashboard within our maternal health hospital report card. You have the ability on this particular dashboard to filter by county, by zip code, by perinatal designation, sort by facility name or perinatal designation, search by facility, or the ability to choose any particular hospital of interest. So we'll just pick a hospital, but every single hospital has the same template, just to keep that in mind. So at the top, you'll always have the location of the hospital, and then we'll focus a little bit here. These facility attribute metrics are from the self-reported data that Mehnaz mentioned earlier, that we've been collecting since 2023, and it really provides kind of service information that the hospitals themselves report to us. Any of this information, you'll see the info cards here for kind of how these are defined. But for now, for example, we have recognition as baby-friendly hospital, lactation consultant availability, midwife availability, implementation of selected AIM bundles, special care nurse or NICU availability, neonatologist, perinatologist availability, and nurse to patient ratio. If the service is available, there'll be a green check mark and a red cross if it's not available. Here is where we show all of our data analysis, again, from that matched data set of birth certificate and discharge data. For the purposes of time, I'll just focus on a few of these, but our selected metrics really bring together metrics from all of these different tabs. And if it's darkened blue, that's the one that you'll be focusing on. You can filter by year. On any of these indicators, you can hover and see the statewide average, and you can also see the statewide average with the orange line here. So for example, here you see race ethnicity breakdown, risk factors, comorbidities, obstetric procedures, method of delivery, and delivery complications. We'll go very quickly to the delivery complications here. This is actually showing the 3 complications that are indicated by the legislation: post-admission infection, SMM, and obstetric hemorrhage. So you have the overall risk-adjusted rate So it's risk adjusted by a number of different factors, as well as the New Jersey average, and then broken down by vaginal and cesarean delivery. These green and red arrows and gray arrows show if that particular complication is significantly higher in comparison to the state rate, no significant difference, or significantly lower. So you can see, for example, SMM here is no significant difference in comparison to the state rate. And again, these are all risk-adjusted complication outcomes. And quickly to our side-by-side hospital view, which might be of particular interest, you can select a number of different hospitals. Just going to kind of pick some kind of random hospitals to look at. So you see the facility attributes here from the survey and a number of the different indicators that we've seen on the other dashboard parts. You can go to map view if you're interested in kind of any other facility to look at. For the purposes of time, I'll go to one statewide dashboard. However, we have also a focus on statewide delivery complication rates and statewide birthing people demographics. So just bringing up the NTSB cesarean birth rate dashboard, you can filter by year, perinatal designation, consortia region, and then you see the rate compared to the statewide average, the average for the selected filter, or the Healthy People 2030 goal, and then by patient characteristics. So you can look at all hospitals across the state or particular hospitals by year and particular demographics. So again, for the purposes of time, we won't do the others, but also wanted to highlight the feedback form here that we really ask people to fill out so that we can continue to improve this work. I'll move very quickly to some of the findings. So first, again, another QR code, if that's easier for some as well, although it was probably, I think, shared in the chat, but you can get to the hospital report card with this QR code. So just a real high-level overview of our findings from our 2024 analysis. For more in-depth information on our findings, you can go to the summary of findings, which I highlighted earlier on our website. But overall, in 2024, New Jersey's 46 birthing hospitals delivered about 95,000 babies, which was a slight increase from 2023. From our particular data, New Jersey Family Care, or the New Jersey Medicaid program, covered over 1/3 of these births. There have been some selected improvements, such as a continual decrease of NTSB cesarean birth rates among all race ethnicities from 2018, as well as overall. Although, of course, challenges remain, non-Hispanic Black birthing people continue to have the highest rate of SMM with transfusion, as well as the highest rate of obstetric hemorrhage, and Hispanic birthing people had the highest rate of post-admission infection. Just really quickly, some results, some impact that we've had with the report card. Our probably most widely used dashboard, the hospital-specific dashboard, has had thousands and thousands of views, so we're hoping it's being used. We continue to have purposeful community engagement and discussions with local public health, culturally specific organizations, maternal health consortia, and are always looking for more opportunities to talk about the data and to share this data. And we have gotten strong feedback about the usability of the applications and always invite more. And I did already highlight the feedback surveys, and these are accessible through the website itself, but some QR codes as well to the feedback surveys. And I will now hand it over to Stephen for the next part of the presentation.
Thank you, Jordan. I'll go through this relatively swiftly. Hope you can hear me okay. So how can we use these data in many different ways? We just highlight 5 different ways real quick. First way, for example, is this for public consumer education, healthcare decision-making. For example, you can use a report card to make informed comparisons among hospitals. There's also information about services available at the hospitals, as well as providing information about potential outcomes or indicators that you may want to address or discuss with healthcare providers. The food security and maternal health web application provides lots of information about whether for the person's own health or their child's health, or of course to learn about more state-run services and programs. So there's data there. So next slide, please, Jordan. Another way is definitely for program planning. You can provide baseline data when measuring implementation of maternal health-related programs. It can also assist in identifying priority or populations of need within hospitals and communities. They can also be used to identify service gaps for specific geographic areas within New Jersey. And finally, they can also assist with many forms of program and service evaluation by looking at specific data trends over time at the statewide level, local level, and facility level. So that's very helpful. Third, these data can be used to help or include in justified grant submissions or other funding mechanisms, which is always an important part. Usually, it's an important part of an application for funding. Likewise, they can be leveraged as, again, evaluative baseline information that can be used to monitor indicator changes over time. Next slide, please, Jordan. And thank you. And lastly, the fourth, advocacy work. They can absolutely be used to illuminate disparities within specific populations. They can be mapped to highlight patterns of maternal health indicators or other social issues. They can be used to back maternal related legislation or other urgent related issues. And finally, they can be used for policy work, whether for analysis or development. They can be used independently. They can be used in tandem with sources of other high quality data, and they can support policy recommendation based on trends over time, as well as monitor the impact of policy implementation. So next slide, and that moves into Mehnaz.
Okay, very quickly, some future growth plans, and we can discuss it more in the breakout session. We are being very thoughtful and mindful about increasing accessibility of data products. So we're working on revamping our website, developing infographics, and starting to think about how to be more intentional and use social media. We do have a goal of establishing more policy level and community partnerships, which are aligned with community needs and to promote cross-sector use. As Jordan mentioned as well, we are developing similar web experiences, highlighting other social determinants or social drivers of health in relation to maternal health, and then integrating or thinking about what other types of data can be added to the maternal data center umbrella so that we get a more holistic view of the maternal health ecosystem. And I think, Kate, I'm going to hand it back to you, right?
Yes, thank you so much. We are going to make some slight adjustments to the schedule and get right over to Dr. Fay Cobb Payton's presentation because um, we will need to end that by 1 o'clock, and then we will come back to our questions and answers. So you can continue to put Q&A in the chat box, and we will be keeping track of it. But I want to turn things over to Dr. Fay Cobb Payton. She is a professor at Rutgers University and runs the Institute for Data Research and Innovation Science. Welcome, Dr. Cobb Payton, and we're so glad to have you. And sorry that we're
Thank
crunched for
you.
time, but I'll
It's
turn things
okay.
over. You can
That's
share
all
your
right.
screen.
Okay. All right. And you should have these. I think I sent them. I'm pretty sure I sent those over very early this morning, but here we go. Good afternoon, everyone. It sounds as if it has been a very rich conversation. Can everyone see that? Okay, good. I was asked to participate in this session, and what I want to talk about is sort of this idea of small data and AI in the maternal health discussion. So I'm going to start with this notion. So I like to start with stories. And I'm going to start with the story where the comedian here from The Daily Show talked to a physician about birthing instincts and trusting nature in the childbirthing process. And while The Daily Show may be a comedic experience, this was a very salient and serious topic. And I downloaded what the script was. And I do want to point out just a couple of things. So it started at the top. There's mention that, cesareans happen somewhere as between 1/3 and 40% of all births. And then the two get to start exchanging, and it says in some hospitals that number could get up to 80%. And it's asked, are women being induced? And the comment was, you mean like cows being induced? This is a medical issue. the comedian says. And the model says that the physician says is that the model sees birth as a problem as opposed to a natural process. And in so much, the physician says midwifery models could certainly help when it comes to building trust in women's bodies. So if you haven't seen that, it's at the back of, I referenced it with a link to the video. It's very interesting. It takes about 5 minutes. So part of the reason for getting into this line of research is given my interests in disease conditions, health conditions, and comorbid conditions. And with pregnancy, there has come, not recently, it's not a new phenomenon that often, whereas life does happen, there is often, and more than enough times, there is loss of life for the mom. This is data from the CDC that we took a look at. And I was very pleased with the previous presentations to hear the word comorbid conditions, because all of the disease episodes or health conditions that I've looked at, we've never modeled in isolation. We've looked at them in terms of comorbid conditions. And so oftentimes, as you can see, pregnancy comes along with other complications throughout the birthing experience or pregnancy experience. And this related mortality rate along race and ethnicity from the CDC data, and we tried to grab this, and got these numbers for 2017, 2019, and took a look at out of 100,000 live births, the number of pregnancy-related deaths that have occurred. Any number is a significant number. And so to that impact, my team and I are very interested in looking at what is the data that's really guiding and the birth experience, the pregnancy experience, and where are we using community-centered data frameworks in order to capture the lived experiences and voices in the process. And so this is sort of a schematic that we use to say, first of all, who's defining the problem? And it really rests on the scientific method. And in the scientific method, you start with the hypotheses or the question. And so right out of the gate in the community-centered data framework approach is who's asking the questions, who's on that steering committee, where are the power plays, and who is not at the table. Secondly, whose experiences are being captured, but whose experiences are missing. Very important in terms of the data experience. And oftentimes, particularly in tech, we sort of, in the past, have used a framework as build it and they will come, not build it with the user as a part of the process. And we're saying when it comes to maternal health, those issues of inclusion must be incorporated. And how is the data used to advance equity? Or are the data used or the model really reinforcing some of the disparities that may exist? And fourthly, how can AI and technology actually help but not replace? And oftentimes you'll hear, particularly in IDRIS, we'll use the term, which is the same term that I used when I was an NSF program officer, is where's the human in the loop, or where's the human in the humanity in the experience? That means understanding community and the wisdom that exists within the community, which is variable and not the same. Where's the accountability and where is the action when it comes to having, all of us here on the call are very familiar with the challenges associated with AI, the black boxing, the quality of the data, but understanding those small data, community wisdom is really important. So this may look a little complicated, and instead of giving bullet point by bullet point, I thought it would be nice to sort of have some graphics when it comes to community-driven maternal health data. Right in the center, one big one, which is not tech, is grounded in trust. Has trust been established? Is it driven by equity, guided by community, but focuses on action? 4 premises: the community voice and who owns the data, who owns the results of the data. Does community even want to share the data? And I'd say a big point is, does community really understand the value of the data? Secondly is an equity-centered data collection around data practices. It was mentioned all of the demographic information, but I will say really centering around avoiding stigma in the approaches that are used, and capturing, and I loved it, the demos that were done, capturing that small data and lived experience through storytelling. What does that mean in terms of observations? But when you get something out of the model for AI, can you encapsulate, can you layer on what the small data are telling you in tangent? And I like to give just one example that's not on this chart. Formerly, I was involved with a research study. I am a professor emeritus at North Carolina State University before joining Rutgers. Had an exceptionally bright student that could run rings around you statistically. We had a large data set, and one of the answers to an inquiry was 0. And she said to me, "There's nothing there." And I had to remind her to go back to the research question. What did we ask? And what did in the context of what we were asking, what does 0 mean? And so just because you get a number doesn't mean that it's not important or significant. And in our context, that 0 was very significant. Having a responsible use, policies and procedures around tools, we call them guardrails. Very important. Also having a transparency so that community will understand, understand and feel protected, but clearly articulating a communications plan with community. Action. When something results from the data, what are the intervention? How will resource allocation and what policies will be differentiated, created, revised, reconsidered, revisited, so that you can move forward with addressing the problems or the issues. And then a shared interpretation of what those findings makes. We call it sense making. It helps with better data, have better data to make informed, better decisions, to have healthier communities. We are currently looking at open data. Open data, in particularly in maternal health, is really what is made available to the public that can be downloaded, usable, reused in formats very much like what the demos were just providing to us. And what are those indicators? What are those indicators, whether they are being monitored or that there are interventions that need to be done? So we have examples here in the slide on health indicators. Who's going to use them? What is not here is actually the patient. Communities, yes, but the patient, the families themselves should be centered as well in the open data discussion. For open data, there are 4 themes that we have attempted to follow. And I put the citation at the end. We want the data to be timely. We want it to be well documented in terms of definitions and architecture. We want it ethically managed. Are there IRBs Are there consensus forms? Are there non-disclosures? And what is the equity focus so we can realign in order to bring the numbers into a more favorable outcome in the maternity health arena? In practice, that means identifying gaps, tracking disparities by place, which I did see in the demo, and by population. It says or, but it's an and drive home those decision-making tools that need to occur. We're also looking at why state comparisons are challenging, because we're interested in seeing not just what New Jersey's doing, but what are other states doing? Is it something that we can bring back to New Jersey? Is it something that we can say, hey, New Jersey's doing great for this, that may scale in other states? Don't know, but we do know from our research thus far that there are 8 factors that make state-to-state comparisons, excuse me, extremely difficult. And I sort of group them in terms of 3 themes. One is on definition of and measurement, and that's variability in that, and we'll talk a little about that. Quality of the data and the methods being used, and then the populations and the systems. And so you can see by definitions and measures, variable definitions, variable measures, inconsistency in equity measures. When it comes to data, oftentimes there are small numbers, and when small numbers result, oftentimes you just see that little dash. And I'm telling you that our research has shown, and through qualitative methods in session, subjects, participants have said there are people behind that small dash, behind that small data that's being ignored. There's an uneven review process, different time lags, and variations in when data are collected. Then the final theme is around population and systems. There are different population characteristics and differences in the healthcare systems across states, and perhaps variability in policy. So what we're saying is that what we're looking at is building better benchmarks, standardizing on national definitions, using risk-adjusted measures, common data standards. This was even my dissertation. This piece is hard, but coming to those standards across states makes it even more challenging. Stratified reporting by all of the demographics, and we're saying insurance status really matters. Small data, geography, the food deserts, the place and the space discussion. Longitudinal within states, and making sure that we can compare from year to year. And while we have different factors that we're measuring, there are process measures. And those process measures include the visits, which means sometimes getting into that EHR, hypertension, smoke count, smoke sensation, and the rest in terms of what happens in terms of healthy babies and healthy moms. I do want to point out this in the time remaining, because that storytelling piece is really important. As New York Times, this was a story that was in the New York Times that took a look at births across the nation. And this was their conclusion. Regardless of income or education, Black women, Black mothers, have the worst birthing outcomes. That was very recent. I will point you to, without small data, AI in healthcare actually contributes to the disparities, because we are training on data that's not necessarily reflective or representative of populations. A piece that is available to you, and I also, it's in Scientific America, put that in the references as well. And I thought this is very important when it comes to taking a look at an international comparison and how, as holistically, how are we doing as a country? And 2 outcomes, or they call them top lines, were provided here. And that was there is far exceeds the maternal morbidity rate, far exceeds those of other high income nations. And then secondly, again, a big reason why Black women in the US um, continue to have issues in maternal health are due to persistent inequities. Very interesting piece. I would suggest that we all take a look at it. But what is interesting is that internationally, the use of midwifery in terms of addressing many of these issues. These are the references. I know that was quick. This is my information. I look forward to continuing the conversation with you. Feel free to reach out and feel free to look us up at IDRIS at Rutgers Newark. Thank you.
Thank you so much, Dr. Cobb Payton. I know you have to run, but we're going to share your slides, and I think you gave us so much amazing information to move into our discussion, and I feel certain you're going to get some outreach from this group. So thank you.
All
We are
right.
incredibly appreciative.
This is a good group. Let's go solve this issue now. All
Yeah,
right.
exactly.
Take care.
Thanks.
Bye-bye.
Um, so we are going to switch back to some Q&A now. And I know a number of questions have come into the chat for our Department of Health team. I will just give a preview of things to come. We are going to move into breakout rooms after that, where we'll be discussing both these larger public data sets that the DOH team reviewed with us, and then also this idea of small data and how it informs and guides the work that we're doing. And of course, we will always second the cheer for midwifery, knowing that we have many midwifery champions here today too. So if you've got questions, please keep putting them into the chat. We'll spend about 10 minutes with Q&A before we move into our breakout rooms. So I will turn things back to our Department of Health team. I know one of the questions that was asked was answered in the chat, but I would just want to highlight it for everyone. The question came in about the maternal mortality and morbidity data. And when new data will be available. So the data that's available right now in the report card is 2024, and 2025 data will be released in the beginning of 2027. The next question I want to highlight for you all is, how do you capture maternal deaths that take place after the immediate postpartum period that might not be covered in sources like the birth certificate data?
I'll take a stab at that, and then Stephen and Jordan, if I miss anything, let me know. So the Maternal Data Center currently, what we put out there is morbidity data, not mortality data. There is the New Jersey Maternal Mortality Review Committee that does review mortality data, but that sits outside the Maternal Data Center.
Thank you. That's helpful. The next question is related to breastfeeding. Although breastfeeding's an integral part of food security, there isn't a lot of breastfeeding data within the Department of Health Maternal Data Center or as part of the story maps. Could you talk specifically about breastfeeding data?
Sure. So, to my knowledge, and I hope I'm right, source of breastfeeding data in the Department of Health would come from either the birth certificate database, and then in the Division of Family Health Services, they do administer the pregnancy risk assessment monitoring survey, or otherwise known as PRAMS. Which is obviously a sample of the population. The birth certificate data and the system that is used to collect that data has changed several times in the decade that I've been at the Department of Health. And currently, the quality of that data is not as reliable as we would like it to be for us to be able to utilize it for any public-facing dissemination. So we haven't utilized that data until such time where the data quality issues can be addressed. There's no plan to use that data for any public-facing data product.
Thanks, Manaz. Going through my questions here. Um, has there been any data collected related to the price of fruits and vegetables, particularly higher prices, and whether this might be restricting access to healthy foods for certain populations or in certain geographic areas?
That's a great question. Unfortunately, the Department of Health doesn't collect that data. But if others know of a data source that we can establish some sort of user agreement on looking at the data and just, exploring ways to use that data, we would be more than happy to have that conversation.
Thank you. And then the next question is, where can we find the data dictionary that delineates the definitions for different adverse pregnancy outcomes?
Jordan, I think you put a link in the chat for that.
Exactly. Yeah. If that is what is being referred to, I did share the measure algorithms, which I highlighted during the presentation, which is available on the Maternal Health Hospital Report Card site. It really operationalizes all the variables and describes how they're developed. And this would probably be the most useful in addition to the methodology, which obviously describes our analysis and data sources.
Wonderful, thank you. And also just a reminder that we will be sharing the slide decks from both of our presenters. We know there is a ton of references in there that you are welcome to follow. So we'll include all of the links that have been added in the chat, as well as all of the resources that Dr. Cobb Payton shared out. Can you explain the meaning and importance of risk-adjusted rates for maternal complications?
Jordan or Stephen?
Steven, go ahead.
So that's a very good question. And you're more than welcome to, I think, Jamie. There's a methodology that's posted on the landing page, the report card. If you take a look at the first, I think it's this page number 5, there is a very detailed description of what risk adjustment means. Reflects a person for health conditions as well as their social, demographic, economic status. And that process is used for taking into account when you're looking at the entire patient population within relation to the outcome. So it essentially, there's a lot of literature around risk adjustment, but it kind of facilitates like a fair comparison among the hospitals, given that the patient populations differ among those patient populations. So all the details in the literature that we use that provide the support for how we do that are in the methodology, but it is to facilitate a fair comparison between those populations within those different hospitals. I hope that helps.
Great, thank you so much. I think that was, oh, we've one additional question and then we'll move to breakouts. Does Department of Health plan to make public more stratified data of interventions or demographics related to the racial impact of maternal health care in New Jersey? Are there plans to rank birthing hospitals based on adverse outcomes or interventions or calls for common data standards? Sorry, I hit you with the number of questions there.
Yes, I'm reading the question now. Stratified data of interventions, demographics. I'm not sure I understand the first question. The second question, plans to rank New Jersey hospitals by adverse birth outcomes beyond C-section rates. So I think the ranking bit aside, we haven't yet determined the best way to rank New Jersey hospitals. But we do produce complication rates other than just C-section rates on the report card, hospital by hospital. And in one section of the report card, you can actually look at multiple, up to 3 hospitals side by side to see what their, not just their patient population, but what some of those outcomes look like for each of those hospitals next to each other.
Thank you. In I think maybe part of the question is in future iterations or as you iterate the report card. And certainly this information, just a reminder that there is that feedback link that was shared. So you can put these questions there. Is there a way beyond looking at three side by side to just look at the whole state and say top to bottom, who does the best on C-section rates?
I just want everyone to also know that, and Stephen, keep me honest here, New Jersey might be the only state, if not like one of maybe a handful that actually puts data out for labor and delivery by hospital publicly. And yes, it required a legislation for us to take that step, but now it's out there and it's getting improved upon every year that we have released the data. So that's the first thing I want everyone to just wrap their head around. And secondly, ranking hospitals requires some additional thought, right? Because you don't want to just rank hospitals and not then be able to defend the math and the thought that went behind it. So my team and we are the math people. We're looking to partner with people who actually understand some of the other things that need to go into ranking hospitals. So I'll just leave it at that, Kate.
Excellent. Thank you. And I think that's a really excellent segue actually to our breakout rooms where we're going to start having some of these discussions. We're going to momentarily split the group up into three breakout rooms. It is not with any deliberate purpose other than the group is divided by three. And so I'll be joined by my colleagues Armony and Maxilia, and we'll be facilitating those rooms. Like I said, we'll have one member of Department of Health in each of them too, as the experts of the DOH data. And we'll be talking a little bit more about how you, from your various places and spaces and lenses for which you approach this work, think about data within your day-to-day lives, within the programs that you lead, and with understanding impact. And so I will say there was one additional question that came into the chat, but I'm moving it to our breakouts because it's such an excellent conversation starter, which is how can we discuss proven ways and strategies to gain initial community trust in order to look at this valuable data to inform our work. So we're not deliberately ignoring that, but we're just moving that into our breakout discussions. As you're being shuffled around to your breakout room, just a couple of logistics. We'll be in our breakout rooms for about 20 minutes and then coming back together because you have had the extreme pleasure of listening to the Quality Institute staff for quite some time on this call. I would invite you all to think about whether you would like to be the spokesperson for your group and be able to deliver back the 2 to 3 big themes or ideas that come out of your discussion. We would love for volunteers instead of voluntolds. And we will see you all in those breakout rooms shortly. And Armini, if you want to trigger it and send us all away. Hey everyone, welcome back. I know we've had a little bit of drop off as anytime we do these longer 2-hour sessions, we know that it's a huge amount of time for people to be here with us. So we appreciate those who are still on. We are planning for once, probably the first and last time, to get you out a little bit early. So you're welcome in advance. But we are all back together from our breakout rooms. Want to do a bit of a round robin to hear from the other groups and just to be able to share out. And so I know I was leading a group, Armini was leading one, and Maxilia was leading one. I don't know if you have someone who volunteered to give the highlights, but I'll turn it over to whomever can come off mute fastest.
I don't mind starting with my group. Hi, everyone. I'm Armini Pierre-Jacques, and I'm a program officer at the Quality Institute. So I will hand it over to the person reporting out for our group, and that is Monica. So Monica, please feel free to come off of mute and share some of our highlights.
Yes, hi, thank you. We had a great group. We went through several different questions and had some good conversations, starting off with where are we pulling and gathering our maternal health data from? And that sometimes can be a barrier, is where are we getting most of our data and how accurate is it? Some folks are pulling from their EMRs, their health records. Some people are getting information from payers from outside payer organizations that share back data. The state website does provide a lot of data that's very useful. And then other outside resources like Leapfrog is someplace else. One really interesting conversation we had is that along with the quantitative data, the importance of utilizing lived experiences and storytelling and incorporating that in as a part of quality data and education, because that is such an important piece of data. Is what did the patient experience and what is their perspective of, their lived, story. So should I go through all of our topics, or are we just doing like one by one?
I think you can just give a highlight summary.
Okay, perfect. Then we also talked about how do you gain trust within your community, and talking about our visibility within the community is very valuable, but also when we do have that visibility, being sure that we're transparent and honest in our communication, reinforcing to community members that, by them allowing us to use their data, they get to be a part of a decision-making process. And one of our group members was talking about a project that they worked on that I believe she said out of Rutgers, maybe, women who delivered in Newark, who were part of a centering group. And then they utilized them as a focus group and, got to learn a lot from, their storytelling and then use that to really build trust amongst those women and within that community. And then what do we do with the data? How does it impact us? We talked about using the data that we have access to drive our quality initiatives, to drive our education initiatives. We talked about team birth and the utilization of the pre-assessment survey atlas, which was able to then provide data on where is the team currently in terms of their communication and their teamwork, and where does the focus need to be to customize the direction for their team birth education to really have best outcomes for those specific team members. And then how do we use data to identify gaps and to deploy more resources? And one person was talking about how important data is to their board and just the importance of data overall. Most decisions that are being made based on data and based on the ability to identify, where focus and resources need to be prioritized, and, to also help prevent wasting resources, being good stewards of any dollars that maybe have been granted or are budgeted for. So making sure that clean, clear data is shared back to those stakeholders, to make the case and to be able to continue or extend or initiate new programs that can make a difference. And then how could the DOH meet our needs? We really didn't get into this one. And unfortunately, somebody had popped something into the chat, but then our room closed before I could see what they actually wrote. But I just think overall, getting data from the Department of Health for women across our state just helps us to prioritize without any bias, and make sure that we're focusing on the areas that we need to, not just for our local people, but for people all across our entire state, because we are all leaders here, and that should really be where we're prioritizing. So thank you.
Thanks so much for your report out. Maxily, I'll turn it over to you.
Oh, thank you. Yes. So our group we were so excited. We jumped right into it. We did not assign someone for the report out. So that person will be me now. So we did jump in I wrote some notes here, into various different data that sources that each organization was using to collect. For example, one organization cited using the Pregnancy Risk Assessment and Monitoring System, also known as the PRAMS data. and linking that with birth certificate data. And that was used to study the effects of social and clinical factors of postpartum depression. And they did find that there were unfortunately data limitations, including like there are some missing variables when you're going through birth certificate gets data and there were issues with raw data, but they did find that type of information to still be quite impactful, highlighting the fact that they were even able to identify that Asian women have some of the highest rates of postpartum depression, followed by African American women. We had someone from Cooper University Hospital who talked about how they worked closely with the Maternal Data Center to track severe outcomes like transfusion, C-section rates, and other forms of maternal complications. They definitely have had some, not a lot of limitations, but some issues with collecting data when it comes to getting information from patients. So how can they strengthen that when communicating with patients to get clear and accurate information from them? And then we even talked about teen birth, how we're using surveys from birthing facilities and centers to measure shared decision making and patient autonomy. We also talked about using the Madam scale. And then we highlighted WIC community clinics and how they're using qualitative data and how they would actually benefit from being able to identify patterns in challenges with cultural communities when it comes to breastfeeding. For so not this wasn't explicitly mentioned, but just understanding how cultural differences can impact the way in which data is read and how data comes out. Because for example, they were saying like for some communities they might not participate in certain things due to the cultural context, and how does that then impact the data that we're collecting for us to understand what is happening in the reality of the world. So I thought that was really fascinating. Our group had some really interesting things to say, but I will now turn it over to you, Kate.
Thanks so much, Max. Likewise to you reporting out, will be reporting out for our group. We just exhausted everyone with the conversation, and so they provided the expertise, and I'll provide the commentary back. A lot of similar themes came up, as were already shared by our other two breakout rooms. But just some unique things about New Jersey, which we are lucky enough to have here in our state in regard to data. The first is our consortia system, who really has access and understanding through analysis and really close relationships with each of the hospitals in the state. The consortia is able to not only look at all of the individual hospital data and help hospitals make improvements based on their data, but also to look at the region of the state for which they serve and really understand a clearer story related to birthing data and maternal health data. The other piece sort of overlaid and intermixed with that is our regional health hub network, which covers all which is split into 4 parts of the state, not to be confused with our 3 consortia, and operates a health information exchange, which has many different data sources that are coming in on a near or real-time basis that help understand the true story of on-the-ground care that's being provided to pregnant individuals and birthing people, particularly thinking about data coming from the PRA or the perinatal risk assessment that's able to be accessed, as well as outpatient OB data that gives real-time understanding into labs and visit notes, which can help understand the story. We also get to hear interesting perspective from our health plans who really think about how they can support their members and understand quality experiences for their members. How does that data equate to the experiences and care that they can provide, both in how they collect data from individuals by using forums like community advisory councils or seeking that information by building first a trusting relationship. And I will say, thinking about the trusting relationship, I already heard that was a stream that was through everyone's conversation. But we also talked a little bit about the importance of compensation. People are giving willingly of their time to provide this feedback, and not just those who are filling out surveys or participating in interviews, but compensating them for that time and then also compensating um, parent or people with lived experiences who are helping to gather that data. This time is valuable, and we need to be considerate of people doing the work and also those who are sharing their stories. Um, and not just through dollars, but also when are we doing these interviews? When are we visiting communities? And are the same communities being visited over and over to share data with no meaningful impact back on them? So thinking about the full data cycle is very important as well. If you're going into a community, for example, our rural communities have gotten a lot of attention in the last few years in terms of understanding disparities that exist there. And so it feels sometimes like there's an overburden of community participation. Really closing the loop and explaining how that data is being used and what programs it's informing so that they can see the true impact of the time that they're spending to provide that person-centered, community-centered information. So I think those were the highlights from our group. I'll pause for a second to see if there's anything that we didn't capture in this report out that people think would be important to share. I will note there were a few different resources for CDC data sets that were available, particularly related to breastfeeding. So we'll be sure to include that in the email that goes out to everyone afterwards. But are there other things that we didn't capture in our report back that would be important to gather and share?
Hey, I'll just chime in really briefly. I know we're getting low on time, but we had a wonderful time talking in the group number two, I suppose, in Mac's group. I just wanted to add, and let me turn my camera on if I'm able. There it is. When we are collecting the data, as you just mentioned with the community piece, how are we sharing that information back to community and doing that in an intentional way that's digestible is probably what I would want to add just in short form, making sure that there's an intentional way that, like you said, if we're thinking about different times of days where we're collecting the data or the presentation of the data, all those different things that are wrapped within that package, how is it being shared intentionally back with community where they can even say that was accurate. I did say that in that assessment, or that doesn't really meet the standard of our community or in this particular area in our neighborhood. So just thinking about that in terms of this context too, I think is important as we collect the share back is super important as well.
Yeah, absolutely. Checking for understanding, making sure that we're capturing things correctly is so important. So thank you for that. I see a couple of comments slash ideas for consideration in the chat, which I'll share. One is understanding whether birth certificate data captures the presence of a doula, or are there mechanisms for which we could capture the presence of a doula to share back that information? And additionally, sharing information related to the use of Family Connect, the nurse home visitation. How are we able to capture and share that information as well? So two pieces for consideration.
Yes, that came from my breakout room. So that question was specifically for the DOH team. Renee posed the first half, asking if birth certificate data can include if that person was accompanied by a doula during L&D. So I know that was a question for the DOH team. And then the second consideration, what about the Family Connects NJ program? So just wanted to just open that question up to the DOH team since it was posed to them.
Okay, I'll take a stab at it. The birth certificate data fields, making modifications to the data fields take time and resources. There's a long queue of data fields currently that are waiting to be added. And not to say that it cannot happen in the future, but in the near future, probably not. The only other thing I would like to point out is the Maternal Data Center team, and I did recently meet with the Maternal Infant Health Innovation Authority. We have been in the survey that we put out to hospitals annually to collect information on data that is not captured in any of our administrative data sets, but we think are important aspects to capture on the report card. In the last 2 years, we have been trying to get more information around doulas in hospitals and asking hospitals, do you have doulas on staff? Do you work with agencies that provide doula support? What percentage of your births do you think doulas attend to? The data has not been the most reliable, and when we went with Mia, what came up in conversation is that in practice, doulas sometimes are not necessarily considered a part of the clinical care team, and therefore, whether doulas are attending to births or not don't always get captured in their electronic health record. And without that being captured, that data sometimes doesn't come to us. And so when we're asking hospitals in a survey, what percentage of births did you have doulas at? They're not always able to answer that question. The birth certificate database, yes, it comes from birth clerks, but birth clerks also need to refer to the patient's electronic health record to be able to pull some of that information to re-enter it into Veri. So that's my very long-winded way of saying, yes, we can make modifications to Veri. It does require time and resources, and then we have to make sure that the remainder of the data collected is still accurate and integrity is maintained. But most importantly, if there is no capturing of doulas attending birth in the patient's electronic health record, even if we were to include that variable in Veri, I'm not sure what the accuracy of that data will look like.
Thanks for jumping in and adding that clarity. We'll keep a pin in that to see how we are able to advance and improve those data sources. Harmony, I'm going to turn it over to you to wrap us up and appreciate everyone sticking on till the very end.
Absolutely. Thank you so much, Kate. So that brings us to the end of our MAP session. I want to thank all of our speakers for just sharing their expertise and then also their time with data and how do we apply that data into our own work. The slides and the recording will be sent in our follow-up email, so all of you will be receiving that. And then we're also going to ask all of you to save the date for our next in-person MAP convening. That's going to be on March 23rd, 2027 at Mercer County Community College. So we're sharing that date with you all in advance to save that date because we'd love for all of you to join and to participate. And then also finally, you all will be asked to take our MAP follow-up survey. It should be sent to you upon exiting this meeting. So please just take a couple of minutes to share your feedback with us. That's going to be used to improve our future MAP virtual sessions. So thank you everyone for your time today, and we hope to see you soon. Have a great day.